This section is about the Chapter 15, all the supplemental injections, and this will start the part 1 of the PDL. You can see on this slide, look at number 4 down on the right, lower right. That is the PDL, or the periodontal ligament injection. It's for an individual tooth. All of these injections on the supplemental injection chapter are for just individual teeth. They're not for groups of teeth. If you were going to give it, you can give them to other teeth in that quadrant, but they would be a whole separate injection. So it's for the periodontium and the soft tissue associated with it. And on this particular one, you can see the blue color on 19, how it gets the lip, and it also gets some lingual. Plus it gets the tooth itself and the bone periodontium around it and the pulp. Another word for the periodontal ligament is also the intraligamentary. You're actually putting the needle in the periodontal ligament area, and that's how they get part of this word into intraligamentary, into the ligament. So easier for you to remember that. For a single tooth in the pulp and soft tissues. So the advantage is you have no lip or tongue anesthesia for them to possibly self-mutilate. Mostly these are used in the mandibular arch once again because there's such success with the maxillary infiltrations and articaine that they don't really need to do this, but they could if they chose to. One thing about this particular injection, in patients who have been given both injections will sometimes say they prefer to have an IA versus a PDL on that on their back molars because they don't have any sense of numbing. And when you after you give it to them and you say, "Do you feel numb?" they can't really feel it like they can when you have an IA. They can tell that they're numb on their tongue and their lip, and so they kind of calm down a little bit. When they don't feel like they're getting numb or not sure, they get really tense when you come at them with some sharp instruments. What happens on this injection is that the local anesthetic will diffuse apically and with gravity, and it goes into the marrow spaces around the teeth. So we don't force the solution. You're going to have some resistance. It's not going to flow as easily as it did when your needles went into that orange or when it goes into soft tissue. There's going to be some resistance there. So, but you still don't force it in there because if you did, it could cause an avulsed tooth. And avulsed can mean like torn off tooth, but it doesn't really tear your tooth off. What it can do, if you inject faster and force that down there and apically, it doesn't have time to diffuse out, so it can kind of lift the mandibular tooth up a little bit, and it will lift it up out of its occlusion a couple millimeters. And so when you bite down, you're going to be biting down, you're going to connect on that tooth that is avulsed a little bit. It's just kind of brought upward a little bit, and it can diffuse back when it finally settles in, and that tooth can go back down where it's supposed to be. But the PDL is very safe for the whole periodontium. You can include a vasoconstrictor. It has no effect, no bad effect at all on the pulp like it did on another of the supplemental injections, but it does not on this. And so what brought this about is that the dentist needed a way to make sure that that mesial buccal root of the first permanent mandibular molar was absolutely numb when the IA failed, or maybe the dentist only needed to get number 30 or number 19 or 31 or something. So this is what can be used in its place. So the PDL came out and was very popular. It's been out for decades and decades. And then all of a sudden it was not popular, and dentists did not want to use the PDL anymore at all. And now it has regained popularity. And the reason is because of all the new delivery devices. Prior to this, they had to give this with a regular syringe, which you can still do, but you have to have, there were, needles that broke off. You're putting a lot of pressure on there with just a normal syringe. And they had enough mistakes that it just lost its popularity. But now that they've made these new devices, it's gained popularity again because it's very easy and it's a way to avoid doing the IA, and a way for these dentists to avoid that mandibular slump that so many claim to happen at least once or twice in their career. This device is just one device. It's called a Ligament, a Ligajet, and some of you who have been assistants may remember your dentist giving this, and if you'll remember, I never saw too many that my dentist gave. It looks like it would be so gruesome on this injection, but the patients did not seem to mind, and in fact they minded less over this than just a conventional injection. And here you can see how the needle, you can go in that way. That's a little diagonal. Most of the ones I've observed insert the needle is penetrating into the ligament, periodontal ligament, more in line parallel with the long axis of the tooth than angled like that, but you could give it like that too. This is very effective in pulpally involved teeth if the infection or inflammation is not present. So this would be a pulpally involved, means a decay. If there is some decay right in the middle of the tooth, but there's no huge infection or inflammation. So you can use a 27 gauge short firmly placed between the interproximal bone and the tooth, just right in the periodontal ligament space. Bevel always faces toward the tooth if it can, and appropriate to bend the needle halfway along the shaft if necessary. There's a very small volume of anesthetic that is given to the PDL. It's in fact a stopper full, which can be 0.2 to 0.3 milliliters. They call both stopper full, and so it is deposited under pressure for each root of the tooth. So if you're doing a molar, you might be giving 4 of these to get 4 of the roots. So what can make this a little more comfortable is using a computer-controlled local anesthetic device or a C-clad, like the wand. Your target area is the depth of the gingival sulcus, and landmarks that you would need to look at are roots of the tooth and the periodontal tissues. Area of insertion along the long axis of the root being treated. You're going to advance the needle on the root apically until you meet resistance. Then you're going to have a very rapid, you're going to go ahead and deposit. You're going to have a very rapid onset, about 30 seconds. Some contraindications to this would be the primary teeth. Primary teeth, if you have a permanent tooth that is right behind its present, maybe you can just see the very tip of it. You would never give one of these two because they have reported enamel hypoplasia in the developing permanent tooth when the PDL is given to a primary tooth. And so the best way to do this is to look at x-rays. And even if the tip of it isn't present, but it's right underneath the gum, ready to the permanent tooth is ready to come right out and push that primary tooth out. If it's just right there, then this would not be a good choice for the possibility of having enamel hypoplasia or some damage to the top of the permanent tooth. But again, there's little reason to give this PDL in primary teeth because they have such great success with an infiltration or an incisive nerve block. Advantages, as obviously, once again, you have no lip or tongue anesthesia, a single dose. You're giving a single dose. Now, it may be a single dose to each root, but it's a very minimal volume of anesthetic. It would be a stopper full only at each root. So it is a great alternative when other methods are ineffective. There's minimal post-injection discomfort. They're not sore like you are with a normal traditional injection. Their post-op complications are highly unlikely. It minimizes bleeding in the area of treatment, and of course there's a decreased risk of toxicity because you're using so little. Disadvantages. Sometimes the needle placement can be difficult, and this takes a learning curve. You need some experience to get really good at the PDL. So the anesthetic may leak into the patient's mouth, also causing a really bitter taste. They don't like that. And you have to remove the needle and re-enter it at a different site. There's a really short duration of pulpal anesthesia with this, and you could tell because if you're only giving a stopper full, it's not going to last real long. So it has to be a procedure that you're going to get in and out of and complete rather quickly. So it is contraindicated in areas, of course, with infection or severe inflammation. And if you give excessive pressure that is needed for this injection, it might possibly break the cartridge glass. And of course, if you're using a standard syringe, and of course that can always cause tissue damage. You need to give a slow injection. You are going to be met with some resistance, and so it will have to be slow, and that is time consuming. And you will experience some ischemia or blanching or whiteness of the soft tissues adjacent to the injection site. That's pretty normal and will go away. If you're going to bend the needle, and you don't have to, but if you're going to on this particular injection, you would want to bend it at the center of the needle shaft and not at the hub. It's just a picture again showing the positioning of the PDL. You can bend it, of course, with the cap and of the needle, or the best thing to do would be to bend it with a hemostat, as they show here. And that's the end of this section about the periodontal ligament injection.